Okay, let's unpack this. We're doing a deep dive today into a really crucial clinical document. The admission protocol for patients with deep vein thrombosis from vascular surgeon Dr. Gregory Weir.
Right, and it's aimed squarely at specialist clinicians and registered nurses, the people on the front line.
Exactly. It gives these incredibly clear steps for managing patients the moment they arrive.
So our goal here is really to give you a solid but brief summary. We want to hit the essential steps, the critical points from this protocol.
Consider it the roadmap you need as soon as that patient comes through the door.
Precisely. And it starts immediately, right? First step, confirm identity, hospital sticker, verbal confirmation, maybe family input.
Standard procedure, but vital. Then making the patient and family feel welcome, reassured.
Absolutely. Then straight into necessary investigations, there's a specific set of blood tests mandated via Lancet Laboratory.
Okay, what are we talking about?
Well, things like urea, creatinine, electrolytes, hematocrit, myoglobin,
Key indicators.
kidney function, hydration, that sort of thing. Exactly. And critically, the international normalized ratio, the INR. Especially if warfarin is involved, that needs daily checks.
Got it. Daily INR for warfarin patients.
Yeah.
What about other things like scans, chest x-rays, dopplers?
Good question. The protocol is very specific here. Chest x-ray, duplex doppler, magnetic resonance angiography, CT angiography, even CT pulmonary angiography.
Right.
These are only if Dr. Weir specifically requests them. They're not routine orders upon admission.
Okay, so don't jump the gun on advanced imaging. Now, medication, always a huge piece. Let's talk Kluxane, Warfarin, Xarelto.
Definitely a critical area. So for Kluxane, that's low molecular weight heparin, the dose is precise. 1 milligram per kilogram twice a day. Very clear.
Okay, and Warfarin.
With Warfarin, you wait for that international normalized ratio result, then contact Dr. Weir directly. He sets the dose. And a key point,
Right.
if the INR is over 2.0, you have to stop the Kluxane.
Right, stop Kluxane if INR is high. And Lancet Labs helps with counseling too.
Yes, they handle the long-term warfarin counseling and set up those crucial follow-up INR checks near the patient's home after discharge.
What if the patient is on Xarelto instead? What are the newer agents?
Then you just administer the dose exactly as ordered. Could be 15 milligrams twice daily, for example. But here's a major warning.
Right.
You absolutely do not give Kluxane to a patient who is already receiving Xarelto under any circumstances.
Wow, okay, that's a critical interaction to avoid.
Which brings us to antiplatelet drugs. Ecotrin, clopidogrel.
Yes, the protocol is explicit. No antiplatelet drugs alongside Kluxane, Xarelto, or Warfarin unless Dr. Weir specifically prescribes it. It's all about minimizing that bleeding risk.
Makes sense. And pain relief, analgesia, also needs careful thought with anticoagulants.
Absolutely. Pain meds are given as prescribed, of course, but there's one hard rule. No non-steroidal anti-inflammatory drugs. No NSAIDs like ibuprofen.
Because the interaction risk.
Exactly. Significantly increases bleeding risk when combined with these anticoagulants. It's just not allowed per this protocol. Okay, so assessment, medications covered. What about just general patient management once they're settled?
Several key directives here. First, always elevate the affected limb. That helps with swelling.
Right.
If it's a leg deep vein thrombosis, the patient needs to be in Trendelenburg position, feet higher than the heart. RMDVT, just elevate the arm.
The oxygen.
Mandatory. 40% oxygen mask, run at more than 5 liters per minute.
Okay. And vital signs. How often?
Frequent monitoring. Blood pressure, heart rate, respiratory rate, SATs, temp every hour for the first 6 hours.
That's intensive initially.
It is. Then it goes to once every 6 hours after that initial period.
Are there things you absolutely shouldn't do on the affected limb?
Yes, a strict do not. No blood pressure cuff on the affected limb, no venipuncture, no drawing blood from that limb.
Okay, protect the limb.
And stay super vigilant for chest pain. Any report of chest pain, you inform Dr. Weir immediately. Potential pulmonary embolism is the big concern there.
Right, critical heads up. The protocol also mentions a full clinical assessment.
It does. Documenting allergies, checking current meds, a thorough circulation check pulses, Doppler flow, color, temperature of the limb. Initially, keep them comfortable, remove tight clothing. Basic hygiene too. Shower with chlorhexidine soap if possible, or a sponge bath.
What about activity levels? Bed rest, getting up.
So initially, yes, restricted bed rest for the first 12 hours. When they do sit up, say for eating, limit it to a 45-degree angle. No sitting bolt upright.
Okay, and later?
Later, once compression is applied and arterial circulation is good, you strongly encourage ambulation. Short walks every 1 to 2 hours. Definitely avoid prolonged sitting or standing, and actively discourage smoking.
Right. Compression is key then. What kind?
It is vital. Dr. Weir mentions the African bandage technique for initial bandaging if needed. Once swelling is down, an orthotist assesses for proper hosiery.
Is there a standard type requested?
Most commonly, it's Class 2 below-knee cotton compression hosiery. And a really important note, TED stockings, the thromboembolism deterrent or anti-embolic type, never requested in this protocol.
Good distinction. Okay, finally, discharge. Getting the patient ready to leave, what's essential?
Make sure they physically have their compression hosiery. If they're going home on Warfarin, confirm they've had that counseling from Lancet Laboratories.
Right, the counseling is key.
Absolutely. Then Dr. Weir provides the discharge protocol paperwork, the prescription for their anticoagulant warfarin or rivaroxaban, any pain meds, and that referral letter back to Lancet for ongoing INR monitoring if they're staying on warfarin.
This protocol really lays it all out, doesn't it? A very clear roadmap for optimal care in these DVT admissions. Following these steps seems crucial for safety.
Undeniably.
So, here's something to think about for your practice. We've talked about critical medication interactions, the risk of pulmonary embolism. How does diligently following such specific, detailed guidelines like these enhance not just that immediate patient safety, but maybe also your own ability as clinicians to anticipate and manage potential problems proactively?